Welcome to today's lecture on gonorrhea, one of the most common sexually transmitted infections worldwide. We have a 20-year-old male college student who presents with a 48-hour history of painful urination and a yellowish penile discharge. This is a classic presentation of gonococcal urethritis. Notice the timeline. He returned 2 days ago from spring break, where he was sexually active with several female partners. The incubation period of 2 to 5 days fits perfectly with gonorrhea. On physical examination, we observe purulent urethral discharge. This is the hallmark sign of gonococcal infection in males. It's important to note what we don't see. There are no genital ulcers, which helps us rule out other sexually transmitted infections like syphilis or herpes. There's no rash or skin lesions, and the inguinal lymph nodes are not enlarged or tender. This case illustrates several important epidemiological points. First, gonorrhea is primarily transmitted through sexual contact. Second, men typically present with acute, symptomatic disease. The purulent discharge and painful urination prompt them to seek medical care relatively quickly. Third, despite seeking treatment, patients may have already transmitted the infection to their sexual partners during the incubation period. Let's examine the basic morphology. First, Neisseria gonorrhoeae is an aerobic organism, meaning it requires oxygen to grow. This is an important consideration when we culture the organism in the laboratory. We need to provide appropriate atmospheric conditions. The most distinctive morphological feature of Neisseria gonorrhoeae is its appearance as gram-negative diplococci. Let's break this down. Gram-negative means the organism has a thin peptidoglycan layer and an outer membrane, and it stains pink with gram stain. But here's the really characteristic feature diplococci. When you look at Neisseria under the microscope, the paired cocci have their adjacent sides flattened together. This gives them a distinctive appearance, often described as resembling coffee beans facing each other. This kidney bean or coffee bean appearance is so characteristic that experienced microbiologists can often identify Neisseria species based on this morphology alone. In clinical specimens, particularly urethral discharge from infected males, you'll often see these gram-negative diplococci located inside neutrophils. We call this intracellular location. The bacteria are being phagocytosed by white blood cells as part of the immune response, but they have mechanisms to survive inside these cells, which we'll discuss when we cover virulence factors. Let's explore the virulence factors and their roles in pathogenesis. Pili. These are hair-like appendages on the bacterial surface that serve as the primary adhesion factors. Pili allow the gonococcus to attach to columnar epithelial cells of the urethra and cervix. Without this initial attachment, the bacteria would simply be washed away by urine or vaginal secretions. Remarkably, gonococcus can undergo antigenic variation of their pili, constantly changing the protein structure. This helps them evade antibody-mediated immunity, because by the time the immune system produces antibodies against one type of pili, the bacteria have already switched to a different variant. OPA proteins. These are outer membrane proteins that also mediate adhesion and invasion. Like pili, they help the bacteria attach to and enter epithelial cells. They also facilitate bacterial aggregation and protect against complement-mediated killing. IgA protease. This enzyme is particularly clever. The mucosal surfaces where gonococci establish infection are protected by secretory IgA antibodies. The gonococcus produces an enzyme that specifically cleaves and inactivates IgA1 antibodies, thereby neutralizing this important mucosal defense mechanism. This allows the bacteria to colonize mucosal surfaces despite the presence of antibodies. LIPOOLIGOSACCHARIDE. Similar to the lipopolysaccharide found in other gram-negative bacteria, LOS is a major component of the outer membrane. It's highly toxic and triggers intense inflammation, which contributes to the symptomatic purulent discharge we see in infected patients. The LOS also undergoes antigenic variation, helping the organism evade immune responses. Outer membrane proteins. These proteins, including pore proteins, serve multiple functions. They protect the bacteria against phagocytosis and complement-mediated killing. Some OMPs also help the bacteria resist antimicrobial peptides produced by epithelial cells as part of innate immunity. Ability to acquire iron. Iron is essential for bacterial growth, but it's scarce in the human body. Gonococci have sophisticated systems to acquire iron from human proteins, like transferrin, lactoferrin, and hemoglobin. This ability to scavenge iron is crucial for establishing and maintaining infection. The source of Neisseria gonorrhoeae is exclusively humans. There are no animal reservoirs. This means every case of gonorrhea comes from another infected person. However, there's an important distinction in how the infection manifests between the sexes, which has major implications for disease transmission and control. In males, infected individuals are typically symptomatic. As we saw in our case scenario, men usually develop obvious symptoms, like purulent discharge and painful urination within 2 to 5 days of infection. Because these symptoms are uncomfortable and alarming, most men seek medical treatment relatively quickly. However, even though they seek treatment early, they may have already transmitted the infection to their sexual partners during the brief incubation period or before symptoms became severe enough to prompt them to stop sexual activity. In females, the situation is quite different and more problematic from a public health perspective. Many women with gonococcal infection are asymptomatic or have only mild, non-specific symptoms that they may not recognize as indicating an infection. These asymptomatic or minimally symptomatic women serve as carriers who can unknowingly transmit the infection to their sexual partners. Because they don't have obvious symptoms, they're less likely to seek testing and treatment, allowing the infection to persist and spread. The mode of transmission is primarily through sexual contact, including vaginal, anal, and oral sex. The bacteria require direct contact with mucosal surfaces to establish infection. Gonorrhea can also be transmitted from an infected mother to her newborn during passage through the birth canal, causing ophthalmia neonatorum, a serious eye infection we'll discuss later. Let's walk through the step-by-step pathogenesis of gonococcal infection. Step 1. Colonization. The infection begins when Neisseria gonorrhoeae comes into contact with mucosal surfaces during sexual contact. The primary sites of infection are columnar epithelial cells lining the urethra in males and the endocervix in females. The bacteria use their pili and OPA proteins to adhere tightly to these epithelial cells. This adhesion is absolutely critical. Without it, the bacteria would be flushed away by bodily secretions. Step 2. Evasion of mucosal immunity. Once attached, the gonococci must overcome the local immune defenses. The mucosal surfaces are protected by secretory IgA antibodies, which would normally neutralize and eliminate the bacteria. However, gonococci produce IgA protease, which cleaves and inactivates these antibodies. This allows the bacteria to persist on the mucosal surface, despite the presence of local antibody responses. Step 3. Resistance to phagocytosis. As the immune system detects the infection, neutrophils are recruited to the site. These white blood cells attempt to engulf and destroy the bacteria through phagocytosis. However, gonococcal outer membrane proteins help protect the bacteria against phagocytosis. While some bacteria are killed, many can survive, and remarkably, some can even survive inside neutrophils. Step 4. Invasion and inflammation. The gonococci then invade through or around the epithelial cells to reach the subepithelial tissue, the connective tissue layer beneath the epithelium. This invasion triggers an intense inflammatory response. The body recruits massive numbers of neutrophils to the site, and these cells attempt to contain and eliminate the infection. Step 5. Pus formation. The intense inflammation results in the accumulation of neutrophils, dead bacteria, dead epithelial cells, and inflammatory fluid. This is what we call pus. In the urethra, this manifests as urethritis, with purulent discharge. In the cervix, it causes cervicitis, with mucopurulent discharge. This inflammatory process explains the classic symptoms: the discharge, which is the pus draining out, the pain from inflammation, and in men, the dysuria or painful urination. Let's discuss how gonococcal infection manifests specifically in males. Primary manifestation in men is acute urethritis, inflammation of the urethra. Men typically develop symptoms 2 to 5 days after exposure, though the incubation period can range from 1 to 14 days. The classic presentation includes purulent discharge from the urethra. This is typically thick, yellow or greenish, and profuse. Patients describe it as spontaneously dripping from the urethral opening, staining their underwear. This is accompanied by dysuria, painful or burning urination. The pain occurs because inflamed urethral tissue is irritated as urine passes through. Most infections among men are acute and symptomatic. The symptoms are too uncomfortable to ignore. This prompts men to seek medical care relatively quickly, usually within a few days of symptom onset. If untreated, the infection can ascend from the urethra to cause epididymitis, presenting with testicular pain and swelling, usually on one side. Patients may also develop fever. While less common than urethritis, epididymitis is a significant complication that can lead to chronic pain and potentially affect fertility if bilateral. It's important to note that gonococcal urethritis isn't the only cause of urethritis in men. Chlamydia trachomatis is actually the most common cause of bacterial urethritis, and many patients have co-infection with both organisms. This is why when treating gonococcal urethritis, we often provide treatment that covers both gonorrhea and chlamydia. Epidemiological implications: while men seek treatment early, preventing serious long-term complications in themselves, they often don't seek care soon enough to prevent transmission to their sexual partners. Men may have unprotected sex during the incubation period, or in the first day or two of mild symptoms before seeking care. This perpetuates the chain of transmission. The rapid onset of obvious symptoms in men, while beneficial for the individual patient, creates a challenge for public health, because each infected man may have already exposed multiple partners before diagnosis. In women, the primary site of infection is the endocervix. This causes cervicitis, which may produce vaginal discharge, intermenstrual bleeding, or pelvic discomfort. The asymptomatic carrier problem is the critical difference. Women are often asymptomatic or have only subtle, atypical symptoms that go unrecognized. The cervix has relatively few pain nerve endings, so cervical inflammation doesn't cause the same obvious discomfort that urethral inflammation does in men. The discharge may be minimal or attributed to normal physiological variations. This means many women don't realize they're infected and don't seek medical care. These asymptomatic or minimally symptomatic women serve as carriers, unknowingly transmitting the infection to their sexual partners. They may remain infected for weeks or months without diagnosis. Pelvic inflammatory disease is the most serious consequence of untreated gonorrhea in women, is the development of PID, which occurs in 10% to 20% of women with untreated gonococcal cervicitis. It occurs when the infection ascends from the cervix, spreading through the uterus, along the fallopian tubes, causing salpingitis, and potentially into the pelvic cavity, causing peritonitis and abscess formation. This spread is facilitated by the fact that the female reproductive tract provides a continuous pathway from the external environment to the peritoneal cavity. PID often develops when other genital pathogens, particularly Chlamydia trachomatis and anaerobic bacteria, ascend along the same route, creating a polymicrobial infection. The gonococci may initiate the process, but other organisms contribute to the ongoing inflammation. Women with PID present with lower abdominal pain, fever, abnormal vaginal discharge, and cervical motion tenderness on examination. However, some cases are subclinical with minimal symptoms. The long-term complications of PID are devastating: infertility due to fallopian tube scarring, ectopic pregnancy because damaged tubes can't transport the fertilized egg properly to the uterus, chronic pelvic pain from adhesions and scar tissue. These complications can occur even after a single episode of PID, which is why early detection and treatment of gonococcal infection in women is so critical. Disseminated gonococcal infection, DGI. In rare cases, gonococci can spread through the bloodstream, causing disseminated infection with fever, skin lesions, and arthritis. Ophthalmia neonatorum represents a special and preventable manifestation of gonococcal infection that occurs in newborns. This occurs when a newborn's eyes are inoculated with Neisseria gonorrhoeae during passage through the birth canal of an infected mother. Remember, many women with gonorrhea are asymptomatic, so the mother may not know she's infected at the time of delivery. When gonococci contact the newborn's conjunctiva, the mucous membrane covering the eye and inside of the eyelids, they cause an acute, severe, purulent conjunctivitis. The infection typically manifests within 2 to 5 days after birth. The affected eye or eyes become extremely inflamed with profuse, purulent discharge. The eyelids swell, and the conjunctiva becomes intensely red. Without treatment, the infection can rapidly progress to involve the cornea, potentially causing corneal perforation and permanent blindness. Historically, before routine prevention was implemented, gonococcal ophthalmia neonatorum was a major cause of blindness in children. This represents a tragic outcome from a completely preventable condition through simple prophylactic measures. In most countries, it's standard practice to administer antimicrobial eye ointment to all newborns shortly after birth, typically within the first hour. 3 agents are commonly used: 1% silver nitrate drops, 1% tetracycline ointment, or 0.5% erythromycin ointment. These agents are applied directly to the newborn's eyes and effectively prevent gonococcal eye infection. This universal prophylaxis approach is used rather than selective treatment because 1. Many infected mothers are asymptomatic and undiagnosed, 2. The intervention is safe and inexpensive, and 3. The consequences of missing a case are severe. The first step in diagnosis is obtaining appropriate specimens. For direct microscopy and culture, we need samples from the site of infection. In men with urethritis, urethral discharge, or exudate. In women, endocervical discharge or exudate. For other sites, pharyngeal swabs for oral infection, rectal swabs for rectal infection, or joint fluid for disseminated infection. Direct microscopic examination of gram-stained specimens is a rapid and useful diagnostic method. Under the microscope, we look for gram-negative diplococci. The image shown here illustrates the classic findings. You can see numerous neutrophils. These are the pus cells, white blood cells recruited to fight the infection. Within these neutrophils, you can observe the characteristic gram-negative diplococci, appearing as pink or red pairs, with the coffee bean morphology we discussed earlier. This intracellular location, bacteria inside the neutrophils, is highly characteristic of gonococcal urethritis. We describe this as intracellular gram-negative diplococci within polymorphonuclear leukocytes. The diagnostic performance of gram stain varies significantly by specimen type and patient population. In symptomatic men with urethral discharge, gram stain has excellent sensitivity, 90 to 95%, and specificity, 95 to 99%. This means if you see intracellular gram-negative diplococci in urethral discharge from a symptomatic man, you can be very confident it's gonorrhea. However, in women with cervical specimens, the sensitivity drops to only 40 to 60%. This is because women often have fewer organisms, and the normal vaginal flora includes other bacteria that can complicate interpretation. Culture, growing the organism in the laboratory, has traditionally been the gold standard for diagnosing gonorrhea. Neisseria gonorrhoea is a fastidious organism, meaning it's difficult to grow in the laboratory. It requires specific nutrients and atmospheric conditions. Additionally, clinical specimens often contain normal flora bacteria that can overgrow the gonococci. For these reasons, we use special culture media. Chocolate agar supports the growth of gonococci, but also allows growth of many other bacteria. Therefore, it's useful when we have specimens from normally sterile sites, like joint fluid, where contaminating flora isn't a concern, but it's not ideal for specimens from sites with normal flora. To isolate gonococci from specimens containing normal flora, like genital swabs, we use selective media that contain antibiotics to inhibit other bacteria while allowing gonococci to grow. 3 commonly used selective media are Thayer-Martin medium, the original and most widely used, modified New York City medium, Martin-Lewis medium. Gonococci require a CO2-enriched atmosphere, 3–10% CO2, for optimal growth. After 24 to 48 hours of incubation, gonococcal colonies appear on the agar surface. As shown in the image, they're typically small, gray, translucent, and have a glistening appearance. The colonies are usually 1 to 2 millimeters in diameter and have a distinctive mucoid consistency. Culture has several advantages. It provides definitive diagnosis, allows antimicrobial susceptibility testing, and has high specificity when properly identified. However, culture has limitations. It requires viable organisms, so specimens must be fresh and properly transported. It takes 24 to 72 hours for results, and sensitivity can be as low as 80 to 90% due to the fastidious nature of the organism. Once we've grown colonies that we suspect are Neisseria gonorrhoeae, we need to confirm their identity. The oxidase test is the first and quickest confirmatory test we perform. All Neisseria species are oxidase positive, but it doesn't distinguish between Neisseria gonorrhoeae and other Neisseria species, including the commensal Neisseria species that normally inhabit the throat and genital tract. So we need additional tests. The definitive identification of Neisseria gonorrhoeae is based on its pattern of carbohydrate fermentation. Different Neisseria species ferment different sugars, giving each species a unique fermentation pattern. We inoculate the suspected gonococci into tubes containing different sugars, glucose, maltose, lactose, and sucrose, along with a pH indicator. If the organism ferments a particular sugar, it produces acid, which changes the pH and causes a color change in the indicator. Neisseria meningitidis ferments both glucose and maltose. Other Neisseria species have different patterns. Modern laboratories often use rapid enzyme substrate tests that give results within hours, rather than the overnight incubation required for traditional fermentation tests. These tests detect specific enzymes produced by gonococci. Some laboratories use immunological methods like direct fluorescent antibody staining or enzyme immunoassay to identify gonococci. These use antibodies specific to gonococcal antigens. The combination of colony morphology, oxidase positivity, and the characteristic glucose-positive maltose-negative fermentation pattern definitively identifies Neisseria gonorrhoeae. DNA probe assays use labeled single-stranded DNA sequences that are complementary to specific sequences in the gonococcal genome. If gonococcal DNA is present in the specimen, the probe hybridizes to it, and the label is detected. These tests are relatively simple, but less sensitive than amplification methods. PCR represent the most sensitive and specific methods for detecting Neisseria gonorrhoeae. These tests amplify specific DNA sequences from the organism, allowing detection of even very small numbers of bacteria. PCR is extremely sensitive, greater than 95%, and highly specific, greater than 99%. They can detect gonococci even when present in very low numbers, making them superior to culture, especially for asymptomatic infections or specimens from sites like the pharynx, where bacterial loads may be low. Results are available in 1 to 2 hours for rapid molecular tests, compared to 24 to 72 hours for culture. This allows same-day diagnosis and treatment. PCR can be performed on a wide variety of specimen types. First, catch urine, especially useful for men as it's non-invasive. Vaginal swabs can be self-collected by women. Endocervical swabs, urethral swabs, pharyngeal and rectal swabs. The ability to use urine samples and self-collected swabs greatly facilitates screening programs and increases patient acceptability. Unlike culture, which requires viable organisms, PCR can be performed on specimens that have been stored or transported because they only require DNA, not living bacteria. This makes them ideal for screening programs and remote locations. PCR platforms can simultaneously test for both Neisseria gonorrhoeae and Chlamydia trachomatis from a single specimen. Since co-infection is common, this is extremely valuable clinically. The recommended first-line treatment for uncomplicated gonorrhea is ceftriaxone, a third-generation cephalosporin, typically given as a single 500 mg intramuscular injection. Dose may be higher in some regions. Ceftriaxone has replaced earlier recommended treatments because Neisseria gonorrhoeae has developed resistance to many previously effective antibiotics, including penicillin, tetracyclines, and fluoroquinolones. Widespread use of ciprofloxacin resistance has developed globally, so it is no longer routinely recommended in most regions, unless local susceptibility testing confirms the strain is susceptible. Because of the threat of resistance and the high rate of co-infection, treatment typically includes ceftriaxone for gonorrhea plus azithromycin or doxycycline for presumptive treatment of Chlamydia trachomatis. This combination therapy has the dual benefit of treating potential chlamydial co-infection and potentially slowing the development of cephalosporin resistance. For prevention strategies, comprehensive sex education is fundamental. Prophylaxis for neonatal infection. As we discussed earlier, routine prophylactic treatment of all newborns' eyes with 1% silver nitrate, 1% tetracycline, or 0.5% erythromycin ointment prevents ophthalmia neonatorum. Unfortunately, despite decades of research, no vaccine for gonorrhea is currently available,